Dear ladies and gentlemen, thank you very much for your participation at this meeting organized by Extra, and I will make the start with a talk on low-dose radiotherapy, the state of the heart. I want to show you, in my opinion, what is going on with low-dose radiotherapy. This is a device. This is an Extra device. This is a device as we use it in our department in Germany, in Erlangen. So I want to go in the talk. So as you all maybe know, low-dose radiotherapy for benign conditions is a controversial issue. In some countries, it's accepted for more than 100 years. For example, in Germany, in other countries, it's regarded as harmful, for example, in the Netherlands or the United States. So why is it controversial? I want to show it in the next minutes. So what about the evidence for radiotherapy for benign inflammatory degenerative musculoskeletal conditions? First of all, I want to start with our own trial. It's a randomized trial with more than 1,000 patients, and I want to explain it to you in the beginning. So we randomized patients to 2 schedules of radiotherapy with 6 times 0.5 grays, with 2 times a week in 3 weeks. And we randomized it to 6 times 1 gray in 3 weeks and made a re-evaluation of the pain after 6 weeks. And then we applied a second series if necessary, with again in the arm A 6 times 0.5 grays, in the other arm 6 times 1 gray. So in the one group they had about 12 grays cumulative dose, in the other group 6 grays. And then we made another pain evaluation 6 weeks after radiotherapy and a long-term evaluation after 2.5 years. And so we included more than 1,000 patients. Some dropped out, and in the analysis we had 1,080 patients, more than 500 in the arm with 0.5 gray single dose, and the same in 1.0 gray single dose. And we included patients only with heel pain, calcaneodynia or achillodynia, with shoulder syndrome and elbow syndromes. And here are the results. We had a dedicated pain score, and to summarize it, here you can see the early response and the delayed response and the long-term response. These were 3 times of evaluation. Early response is directly after the last radiation. Delayed response 6 to 8 weeks later in the follow-up visit. And for the long-term response, we sent out a questionnaire 2.5 years later, and this is what we got as the answers. And you can see the response rate is a combined complete and partial response of the pain, of the initial pain. And right after radiotherapy, you can see that 84% of the patients said the pain was better. And 6 to 8 weeks after radiotherapy, it was 87%. And in the long-term analysis, 2.5 years later, it was over 90% of the patients. So you see the response is increasing with time. This is well known. And if you look to the no change or non-responders, it was right after radiotherapy 16% and 8% after 2.5 years. We received letters of more than 700 patients. So you see that there's quite a good, it's quite effective, the low-dose radiotherapy for this kind of conditions. And what else is very interesting, right after radiotherapy, the complete response is only 5%, and this increases up to nearly 50% of complete response with time. So this is quite a nice finding. The majority of patients benefit from this kind of therapy. And parallel, we did another endpoint analysis as well for pain with the visual analog scale, and we measured from 0 to 100. And here you can see the baseline values before radiotherapy, after the first series, before second series, after the last radiation, 6 to 8 weeks after radiation, and after 2.5 years. And what you can see, that it's steadily going down, and the lower the rates, the less the pain. So it's another point that it's working very good, it's effective, and what's very important, that you can see a difference between 0.5 grays and 1.0 grays. So to give only the half of the dose is same as effective as 1 gray. This was a very important finding, and therefore in Germany we usually apply single doses of 0.5 gray for this kind of problems. And if you show to the details afterwards, the further treatments after the low-dose radiotherapy in follow-up, and there were some treatments, manual therapies, medication, surgery, radiotherapy again, and so on. And there was as well no difference between the two arms, and this supports 0.5 grays. Would you recommend radiotherapy for the patients in the two arms? There was no difference at all, and both arms were equally effective. So in this slide, I summarized randomized trials focused on single dose. Here you can see two trials from the Netherlands with not a very big patient sample size, and after 3 months there was no difference between 6 times 1 gray versus sham placebo. And there was another trial for a hand osteoarthritis, and it was the same. There were some trials for calcaneodynia, heel pain, and there was no significant difference, as well as in our trial. And the only trial that showed a significant benefit regarding single dose was a small randomized trial from Germany, randomizing 6 times 1 gray versus 6 times 0.1 gray, and there was some benefit for this arm with more dose. So I showed you some randomized trials against placebo and against various single doses, and there's no clear picture. So we have to take a closer look. So I want to show you some trials. It begins in these early 70s with a Swedish trial, and it was a double-blinded trial with approximately 400 patients, more than 400 sites, with various entities, variable dose concepts, short follow-up, and this trial, double-blinded trial, showed no effectiveness for low-dose radiotherapy. And it was the same with a Finnish trial, the same design, not very standardized, and about 100 patients, not effective in this double-blinded study. Again, and this is the German trial for the heel pain. 62 patients randomized with calcaneodynia. This is what I told you before. 6 times 1 gray versus 6 times 0.1 gray in 3 weeks. And after 3 months, there was a benefit. And after 12 months, more benefit. And I will not go into the details because we will get this in the next speech from Richard Schatter. So there's another trial, randomized trial from Turkey from 2015 with 128 patients, again with heel pain or foot pain, and they randomized radiation therapy against steroids, and here low-dose radiotherapy was superior for 6 months at least. And also, as well for this trial, we get the details in a few minutes. I will skip this. There's an English trial, just to complete the picture, with 40 patients randomizing low-dose radiotherapy for plantar fasciitis again, with platelet randomized versus platelet-rich plasma. And no, in this trial, there was no benefit shown for low-dose radiotherapy. And now we go on to the more current randomized trials. I already mentioned the 2 trials for the hand osteoarthritis and knee osteoarthritis. Let's have a look to the hand osteoarthritis trial with these 55 patients, randomized low-dose radiotherapy 6 times 1 gray versus sham. At 3 months, there was no difference. The response at 3 months was the primary endpoint, and there was no difference from low-dose radiotherapy against sham. And secondary endpoints, they analyzed very well MRI images and ultrasound images and laboratory endpoints, and they did not find any differences between the 2 arms. Here, the results as a picture. Here is the proportion of responders, and here at 3 months, you see between sham and low-dose radiotherapy, there was no difference. After 1 month, there was a little bit advantage for low-dose radiotherapy, but after 3 months, there was no benefit. And in this trial, the conclusions of the Dutch people were no benefit, and we cannot advise it, low-dose radiotherapy, for the use for osteoarthritis of the hand. And in the second trial from the Netherlands, focusing on the knees, we have the same results. So sorry, in the beginning, I already showed you the results for the knees, and it's the same for the fingers. And the hand osteoarthritis trial is the same results, no benefit at 3 months. Sham was even a little bit better, and but it was not significant, and the conclusions are the same. No benefit, and we cannot advise it as a treatment for hand and knee osteoarthritis. So there's another randomized trial that is not published yet, but will be published in a few weeks. It's a German trial on knee and hand osteoarthritis. And they randomized 6 times 0.5 grays, again, versus 0.05 grays. So standard dose versus approximately nothing. And yeah, it's not published. I cannot show you the results. So where are we now? I showed you randomized trials, and I just want to summarize it. We have a huge body of evidence that clearly proves the effectiveness of low-dose radiotherapy for musculoskeletal conditions. But the data, as I showed you from the randomized trials, is really not convincing, and therefore, this is my opinion, the time has come to initiate randomized trials with clearly defined treatment schedules, convincing endpoints, and standardized response evaluation, and of course, adequate sample sizes. So we have some work to do, and thank you very much for your attention.
Thank you, Dr. Ott. As Dr. Schaffer had mentioned in the beginning of the session, we'd like to go ahead and open it up to Q&A. I'd like to kick it off, Dr. Ott, with a quick question around the controversy. I think you highlighted some of the controversy with respect to some of the clinical results that you're getting compared to the randomized clinical trials. Do you have any other observations regarding the use of low-dose radiation therapy in certain countries versus others that you can share with our attendees?
Yes, in most German-speaking countries and some other European countries, for example, in Spain, it is very popular, and thousands, tens of thousands of patients were treated every day, whereas in other countries, they try everything to eliminate this kind of radiation for benign diseases or conditions. And yeah, it depends on the school that you are from or what you think about radiation in benign diseases. And so it's in the end, it's radiotherapy, it's ionizing radiation, and this is maybe in theoretical point, it's harmful, but in our experience in a lot of countries, they see no secondary or no tumors as a consequence of this treatment. And if you go to the literature, you do not see publications about the induction of malignancies. And therefore, we think in Germany that's quite a safe treatment, but from a theoretical point of view, you can have a different opinion. And of course, we all want to spare radiation where it is possible, using the ALARA principle. And yeah, we tried to do it, but in the end, you have to decide if you want to use it or not. And we have a lot of happy patients here in Germany.
Okay, thank you. Next question, what was the energy used for the treatments?
The energy, usually in our trial that I showed you, we used auto voltage radiotherapy between 120 for the elbows, kV, kilovoltage, up to 220 kV for the shoulders and yeah, the heel pain.
Okay, thank you. Next question, how was the dose prescribed? Did you prescribe it to a volume or to a point?
We described the dose in our trial to the surface and not to a volume. So this is no 3D planning for comparable. It's not comparable to LINAC therapy. We do not use the LINAC, and we do not use individual pre-planning. So we use tables and points.
Okay, thank you. Next question, what is your preferred RT schedule? Is it 6 times 0.5 gray, 2 times weekly?
Yes, that's it. And we do this over 3 weeks. And then we have nowadays a break of 10 to 12 weeks. We wait a little bit longer than in the trial I showed you, because you've seen it's the response is increasing over time. And therefore we wait now 10 to 12 weeks. And in case of subjectively insufficient response for the patient, we advise a second series. And after 6 to 8 weeks, we had 80% of the patients with 2 series applied. And nowadays, we think it's a little bit less.
Okay, there are a number of questions around your treatment with orthovoltage versus megavoltage, so I'm going to skip over those since you just answered those. The next question is the response different in older versus younger patients?
There's no clear data for me. I just can say if an inflammatory condition is quite acute, it's quite prominent in the pain, the response is a little bit better. And we treated some younger professional sportsmen from soccer clubs from the region here, and usually they got one series and the pain was gone for the knees or the feet. And so we have some idea that younger respond a little bit better than older ones, but I do not know data about this.
Okay, follow-up question to that discussion. What is the lowest age limit that you would deliver RT for inflammatory conditions? Would you cap it at 30 years old, or do you treat younger adults?
No, for radiation protection issues, we limited up, the youngest age is 40 years old. And this is what we wrote down in our national guideline. 40 years is for this benign situations.
Okay. Next question is regarding treatment with LINAC. Would you recommend 6 MV treatment with LINAC?
This is done by the majority of the German centers because orthovoltage devices are not as popular as LINACs in Germany. And yeah, there is a lot of publication about LINAC treatment, and it appears the same effective, but there's no randomized data on this. I cannot give more evidence on that.
Okay. Next question is around your prescribed dose. Just to clarify, did you prescribe the dose to the surface as well for the knee and shoulder treatments?
No, that's right. We prescribed it in the middle of the joint, and we used 2 orthogonal beams, and yeah. And
okay.
Yeah.
All right. Next question. Are there any contouring guidelines for inflammatory conditions and immobilization?
At the moment, it's always said to include the whole joint with the structures that are related to the joint. And I know that experienced radiation oncologists are working on contouring guidelines, but at the moment it's not available in detail. Because one problem is if you irradiate inflammatory conditions, you do not really know what the target is in the joint. Therefore, it's a little bit complicated to define target volumes.
Okay. We have time for a couple more questions, and then we need to move on to our next presenter. The next question is, are there any other indications you consider to be acceptable off trial?
Usually in Germany, in our daily practice, we use this as a routine treatment for calcaneodynia, for knees, osteoarthritis, for and sometimes at the LINACs for the hip osteoarthritis. We do not use the orthovoltage device for that because of the penetration depth, and we use that for the elbows, the fingers, the hands, for the shoulders, and that's it for the inflammatory indications. We do not use this for the spine or morbus Bechterew or so. This is what we're not doing. We use this for fistulas and yeah, and of course for the big topic of hyperproliferative diseases, but this will be discussed tomorrow.
Correct. Yes. Thank you for mentioning that. So for all of the attendees, as Dr. Schaffer mentioned, we have another session tomorrow on hyperproliferative disorders. If you haven't already registered, you can do so at our website. So final question, do you apply a third or fourth series after a year or 2 years? Or retreatment?
Yes. If we had a response of the first or second series, if we've seen a real response to a pain reduction that lasted for a significant period, maybe 1 or 2 years, and older patients are returning with, again, the same situation, we apply a third series. And the minimum interval is 6 months. We always wait 6 months at our department for re-evaluation. And if we do a third series of another 6 times 0.5 grays, we wait again 6 months for re-evaluation. And in some cases, when the age is quite high, we choose to give a fourth series. And if someone is 90 or above, I would give a fifth or a sixth series, because I do not expect 30 years later an induction of cancer.
Sure. All right. Thank you so much.